So we'll be covering this instruction course on one of the very important complications following cataract surgery, which a cataract surgeon or any intraocular surgeon is bound to across, which is post-operative endophthalmitis. So we'll be just discussing about the practical tips and tricks to manage such scenario. And I would like to give you a brief introduction about the faculty because they will be covering each and every topic diligently. And first we have with us Dr. SPS Grewal, renowned eye surgeon in Chandigarh, and he's CEO of Grewal Eye Institute. Then we have Dr. Ajay Arora. He's also coming busy in some other instruction course. He is director of Delhi Retina Center, Vision Plus Eye Center, and he is a senior consultant to Max Hospital and Grewal Eye Institute. And Dr. Neeraj Yadav is with us, who is the senior consultant and head Vitreoretina Services, Narayana Netralaya, Bangalore. He will be shortly joining. Dr. Satish Agraharam is director of Anand Vitreoretina Institute. Unfortunately, he is not able to come, so Dr. Ajay will be covering his talk. And we have with us Dr. Saurav Luthra. Dr. Saurav, please come over. He is director of Drishti Eye Hospital, Dehradun. And I am Dr. Neeraj Sanduja. I am director of Delhi Retina Center and consultant in Fortis Hospital. And the topics which we will be covering are prevention of endophthalmitis, what should be the OT etiquettes, how to differentiate between TAS and infection, how should we give intravitreal injection, and how to do vitrectomy, what is the rationale and timing, and what is peculiar about post-anti-VEGF endophthalmitis, and what is so peculiar about diagnosis and management of late onset and fungal endophthalmitis. So I will request first our Dr. SPS Grewal for his talk on OT etiquettes for prevention of endophthalmitis. And we'll be having some case-based discussion also after every talk, so that we need your interactive discussion also along with you. Dr. Grewal, please.
Hello. Good afternoon, everyone, and thank you, Dr. Neeraj, to give me a chance to share some of the thoughts from GEI and how we manage the operation theatre. This will be more a walk through the way we handle our operation theatre, and it is be touching not onto the finer points actually what we do, but more onto the broader concepts and the philosophy that one need to follow to have a proper OT etiquettes and to decrease the incidence of endophthalmitis. Post-operative infection following eye surgery is a serious complication. Every one of us has experienced it, everyone dreads it, and everyone has spent a lot of sleepless nights over it. A proper OR management is very crucial for decreasing chances of post-operative infection. And at the beginning, if you ask me what is the mantra for that, it is don't let the bugs come in. Unless your theatre is a factory which is producing these bugs, then it's a different story. Otherwise, the best way to prevent endophthalmitis is don't let the bugs come in. And that is what you have to think about, how the different routes through which the bugs can come into the operation theatre. And you have to plug each and every route and each and every loophole so that they do not reach your OT, rather than let them come in and then trying to find the ways to eradicate them. For that, you need to create a system of running your OT, and then you need to monitor it, and then you need to have surprise check to see that whatever you want to be done is being done in the theatre or not, all your protocols are followed or not, or there is some junior most employee who's breaking the protocols and therefore putting our patients onto high risk. The first step in creating a system is to list down what is necessary to maintain the OT sterilization. Aim to make a perfect system, taking one step at a time. The system could be just on a paper or an Excel file, or as you grow, it could be a software or a ERP, but first start from where you are. Creating a system is not enough. You have to also control the system. No system is complete without a person monitoring it from the top. You cannot leave the monitoring to the junior most person. A student who is appearing in exam cannot mark his own paper. It has to be marked by someone else. Therefore, the next step is to arrange for daily and regular supervision. in the initial stages, you'll have to give more of your time to understand whether the methods work or not. Then as you get a grip over the methods, monitor them from time to time. Monitoring is daily activity. A particular task may be monitored at different frequencies, varying from alternate days to once a month. Surprise checks are important because that will give you an idea how your OT staff works in your absence. Always remember that you should never leave the game till you have won it completely. So define your parameters for achieving victory. The best way to be in the game is to keep raising the bar as you move along. So when you're creating a system, you must have SOPs for each and every task that is done in the operation theater, including the material coming in. Do you quarantine the material which comes in? What is your protocol of the material coming from the market and reaching your OT? What are the protocols for carbolization, sterilization, instrument cleaning, all those things, air conditioning, all those things need to be written down in very clear-cut SOPs up to micro level so that a new person should be able to read that document and perform the task accurately. Find the gap between the way you are doing and what should be done. Modify and refine the protocols. And please remember that all the SOPs should conform to the international guidelines which are available on the net for each and everything. Do spend time on net, look for the standard protocols, look for international guidelines. There are a lot of organizations who are making these guidelines and putting them on the net. And that is what you should be looking at, and based on that you should be making your SOPs. And SOP will look something like this, carries the name of your place, then it has its serial number and date and updates when they have been done. What are the inputs or things required for that? What are the ways to do it? These are the detailed step, and what is the final end product. Now once you have the SOPs, and then for monitoring, you need to have checklist where each team member will check what they have been done. One of the examples can be like this. This is the OT checklist. The left half is to be ticked in the morning when the OT starts. The right half is at the end of the day when the OT finishes. So when I go in the morning, I see the list, it's pasted on the wall, I see the ticks, and then I just have a quick look that have they done it correctly or not. So this is important that you have a checklist at the start of the OT and at the end of the OT, and close monitoring is required, for which a surveillance TV camera is a good thing. And it is important to monitor the theater air. It should go ahead, it should have the recommended exchanges, it should have positive pressure, it should have the HEPA filter, and this should take care of, to a great extent, your airborne infections. So if you have a proper filtration and you are monitoring the filters, each filter has a life. Are you replacing the filters? Do you have a timetable of the calendar of the next 2 years that which room, which AC filter is going to be replaced? All these things are important in preventing the infection. One of the very important basic thing is that in your theater, anybody who enters the theater, does he wash his hands or not? Single most important thing in hospital acquired infections is through the hands. And single most thing which has reduced the incidence of infection, some of the major hospitals in the United States, is hand wash. It's very simple thing, very important. I hope most of us in the OPD are doing the sterilum after each and every case. We are changing the chin rest after. Similarly in the OT, any person entering the OT, even if he has gone out for 5-10 minutes, must have a hand wash. Entering into the OT should have a sterilum only then, because it's important to prevent the bugs going inside the OT. Then you keep a record of SSI, the surgical site infections. Whenever there is an infection, you have again set protocol through which the whole process will be going. I'm touching not onto the medical part because that will be coming, that what will you do, or this is on the management or administration part thing, that what all needs to be done in those cases. Are you documenting those cases, and based on that, what action you, how root cause analysis you do, and what action you are going to take on that. You must have an infection control committee which includes the doctors, it includes the administrator, and it includes the nursing staff. And it is very, very important to have infection control manual. All of those who are NABH certified know about it. The infection control manual contains the First, it contains the policy. Policy means that what the organization wants to do. The second are all the SOPs are compiled into it. So the infection manual is almost a 100-page document which is revised every 6 months, which have the major policies, and based on that, all the SOPs are compiled into that. All these things will work if you have a very good staff training program. If you are looking at the qualification of the people whom you are getting into your organization and how you define their privileges. Privileges means who in the theater is allowed to do what, which includes privileges right from the lowermost staff up to the doctors. So the staff training, their qualification verification and privileges are important. Besides the culture, having a good culture of working in the OT, we have to get OT cultures on regular intervals. This is how we do it. This is the map of the operation theater. And what you see in yellows are the locations from which the sample will be taken. The numbering of the location is done in such a way that it indicates what media is going to be used for collecting it, what is the serial number of that. Now, based on this, we have made a calendar, which is the annual calendar, with this calendar shows that every month, what are the different locations from where we are going to take the sample. And one location may have its turn again after about 4 months or so. So every month, a set of samples go, and once the report comes, at the back of the report page, we'll print out that what was the sample taken, from where it was taken, who checked it, what is the report, what further action is taken on it. And also it'll blue, what you see is the blue, this report belongs to this sample taken from this OT at this location. And then all this is compiled into a separate data sheet where you can immediately look at that what is happening into the OT, how the air is being maintained in the OT, what is the sample from the water, what is the sample from the trolley, from the scrub area. So all those details you can have a quick look. It's also important to have a good biomedical waste program. They are fairly streamlined now, and I hope everybody is following this segregation right at the source. And now there are companies who take the biomedical waste and they take care of it on their own. This is the record of the SOP for the biomedical waste and the record which is maintained on every day. It's a good idea to look at the OT utility rate, that you are not overusing your operation theater, therefore putting more load onto the system in the OT than it can handle. OT supplies and supplier performance, again very important. At our place, the new material will come into the OT only on a Saturday, so that it has a cooling time, and then they have the sterilization going over the weekend. Otherwise, during the week, no new supply will come inside the OT. Look at the expiry date. We maintain the record of the medicines which are likely to be. Do take care of the sharp needle injuries to the staff. Cleaning of the instrument is something where you must observe your staff doing it. If you don't observe, then for 1 month, their way of cleaning the instruments will change. They will have shortcuts. They may not do it properly. They may not dry the instruments properly. So this is something which you must yourself observe at random to see that they are doing it. If the instrument is not cleaned and not packed properly, this may be a risk for the next patient that is going to be operated. Similarly, near misses and medication errors along with the sentinel occurrence events, they should be recorded. Rescheduling of the surgery, why you have to do it, some of the medication of errors that need to be looked into it. And autoclaving is again one main component which is giving the whole system autoclave instruments, sterile instruments. This is the way we keep the record. For each case there is one set, and in that one set inside the instrument tray there is a bioindicator. That indicator has to be shown to the consultant before he starts the surgery, and it goes into the register where details of the patient are there. So if there is any patient has some issue, we can go back and see exactly what lot it was and what was done, and we can trace back and do the root cause analysis on this. Mobiles are something which have the highest contamination of the bugs, and mobiles should not be allowed inside the operation theater. We have what you see on the right side is the cell phone jammer, and we have a cell phone jammer in the area so that you cannot use the phone in that area. it's very important to maintain a proper temperature and humidity. This is the chart where every day, every 2 hours, the temperature and humidity in the OT is recorded so that they can pick up some change taking place into the air conditioning and get the right person and collect it. Fogger and carbolization, similarly, record is maintained. And then you have a master list of the OT, and then we have a QA scorecard which goes into the monthly meeting, which gives a report of all the different parameters in a nutshell which need to be monitored. And I prefer that instead of all computerized, because clicking a mouse is very easy, I prefer things to be written so that when a person is writing, there is more involvement into it. And this is the Operation Theatre training module. This is a presentation which includes video. It has a presentation. At the end, it has a question answers which the team have to answer. And this is on a regular interval, the training of the whole of the staff will be continued. So we believe in a teamwork in the Operation Theatre. And the team means that you train them, you educate them, you award them, and you motivate them. And you need a good team to have a good Operation Theatre so that you don't have to spend sleepless nights after eye endophthalmitis. Thank you.
Thank you, Dr. Grewal, for showing us a very ideal system of doing following OT protocols. I have a question for you, Dr. Grewal. We say proper OT etiquettes means you have shown the infrastructure and the personnel management also. But as far as sterilization and infection control is concerned, we have seen if we are a good phacosurgeon having cases maybe 15, 20 or 30 lined up in a day. So whether we should change the trolley every time, we should change the handpiece every time, whether we should change our fluid every time, what should be an ideal scenario which could be cost effective also and ideal also?
Very simple. The answer to that is, if you had to get a surgery done on your eyes, what would you like it to be? And the same should be for all our patients.
So means every case we need to have new set of instruments?
If not the handpiece, at least the part that goes into the eye, at least the tip should be changed.
Tip should be. And yes. Sir, what is your take on whether we should change the fluid for every case? Because most of the cases in cluster endophthalmitis, it is the fluid which is responsible for cluster endophthalmitis cases. Whether it will have any impact
I would put more emphasis on the purchase of the fluid, and it should come direct in bulk from the manufacturer or the main distributor, not from the local market. It's important that it is properly stored, a fresh stock, and it is inspected before you do. Because if there is a problem in the fluid, if you go through last 10, 15 years, whenever there is a problem with the fluid, everyone has reported that they could see a particulate matter, but that was noted after the incident happened. So if you have a protocol that all the bags are examined against the light, they are stored properly, they are not purchased from any of the vendor within the town, this can be taken care of.
Yeah, very important point, very valid point, sir, too. Audience can have one question to Dr. Grewal in case they want to ask. Then we'll move on to next talk. Can we have a mic? Sir, can you please come to the mic?
Is it good question? What I said is that you have to find out all the different ways by which bugs can come into the operation theatre and try to control them. I presume that if I have selected a case for surgery, he doesn't have an infection in the body. If he has a boil, if he has an ulcer on the foot, if he has a cough, we are not taking them into the OT. Yeah, clothes are always. Each patient that goes into the OT has a kurta, pajama and a cap. They don't take any clothes inside except their underwears. All clothes must be changed. We can discuss it after.
I think we'll have one more question.
I strongly advocate never operate a case without beta-T.
I think 3 minutes contact time before taking of surgery is a good thing, and it takes care of most of the preoperative prophylaxis. Now we have with us Dr. Ajay Arora, who will be talking about the diagnose and differentiate task versus infection and immediate management.
Thank you, Dr. Neeraj, and good afternoon for giving me this opportunity of being here in the course. This is the ideal post-op status of cataract surgery which we would have, and this is the dreaded complication of having post-op infection, which can come in various forms, and this led to the ban of Avastin. Because it happened in Modi land, it was banned because 15 patients lost their eyesight, and that was because of infection following endophthalmitis. And this was a headline on a newspaper which said, "Murder at a health camp. The patients got blinded after cataract surgery," which happened in Raipur. Not only Raipur, it happened in New York also. Avastin injections are reported to cause blindness. Therefore, it's very important for us to understand the process of infection and inflammation in the eye and to take appropriate management. So this is the most feared complication. Although the incidence is low, but a single case can be stressful and challenging. It can also disturb the flow of your patients in the outpatient. Even the patient who would have got operated your case otherwise meets a patient who has had an infection will think twice. So we may sometimes want to segregate cases. So what is the treatment options available? We have intravitreal injections of broad spectrum antibiotics. We should take samples for evaluation of the infection. We should start systemic antibiotics that cross the blood-retinal barrier. We should use frequent topical antibiotics. The subconjunctival injections are no longer used. We must talk again and again to the relatives to explain the gravity of the situation and discuss the treatment option. Monitor these patients regularly, sometimes even twice a day if an infection has occurred. Once sure that it is not fungal endophthalmitis, we may need to use steroids. And if intravitreal injections are to be repeated, consider intravitreal steroids. Now, why do we need to inject intravitreal injection? I think Saurabh will be covering more of this, but basically because we have two blood-retinal barriers, an outer and inner, the outer one by the RP, the inner one by the capillary endothelium. And the EVS recommended amikacin and vancomycin, which later on multiple studies have shown to use vancomycin and ceftazidime with the use of an oral antibiotic like ciprofloxacin, which crosses the blood-retinal barrier of 750 milligram twice daily. You must choose 1 gram positive and 1 gram negative antibiotics. So ideally, we normally use Vanco and Cefta. We take a sample so that if we have to change the antibiotic, we change it subsequently. We may add dexamethasone, voriconazole, and amphotericin B. Now, what happens with the intraocular antibiotic and systemic injections? So if you see here, this is the intravitreal injection which is given. The minimal inhibitory concentration gradually comes down over the period of time, and that is the time when the systemic antibiotics are increasing, and that is when, so they should be used. But one should use antibiotics which can cross the blood-retinal barrier, and typically we either use ciprofloxacin or getafloxacin. It's important to take the samples immediately, and this should be done ideally both aqueous and vitreous samples. They should be transported in a tuberculin syringe with a needle turned and capped in a ETO pouch, or they can be, the best way is to inoculate them and put them on the culture plates in the operation theater itself. What you should do is to take 2 slides, one for grams and one for KOH. You have to have a 3 solid media, blood agar, chocolate agar, and seborrheic dextrose agar. Then you have to have 2 liquid medias of BHI and thioglycolate broth. So this is how you should have the armamentarium in the operation theater. Ideally plate them in the operation theater, or you should send them to the lab as soon as possible. It's important for us to know what is the common organisms we are getting in the country, and it's important to find that we have a lot of gram-negative bacilli which was not reported in the EVS study. And appropriately, we have to choose the antibiotic. So if you find Pseudomonas, if you find a gram-negative bacillus, you must look at that it is a commensal, so you must suspect the supply. If you have a gram-positive cocci like a staphylococcus, you must suspect the personnel. And as a question was asked to Dr. Grewal just now, that it is not only the staff and the patient, so you should suspect the personnel. And if you have gram-positive rod, you should suspect the apparels, and that is the role of changing your clothes when the patient is coming into the operation theater. So there are various ways of investigating. In addition, I will not go into much detail, but you can do a PCR analysis. This is the vision chip from Shankar Netralaya, and this is the PCR analysis available all over the country. And you can do X-Cyton, which has got an expanded list of endophthalmitis profile where all these organisms can be tested. It is very important before giving intravitreal injection. The two most important concepts are to use topical betadine for about 3 minutes in the conjunctival sac, and second is to make sure that the eyelashes do not come in the way when you're giving the intravitreal injection. One of the ways is to actually use a bladed speculum so that the eyelashes do not come in the picture. We must have this chart in the operation theater, which is available with AIOS, and you can easily get it, which was thankfully to CIPLA that it was available, and you can get it from them. It must be in the operation theater because you should know how to dilute them. And if you do not want to do that, an e-kit is available from Orolab, which has got all the ingredients of giving the antibiotics, taking the sample, and sending it for culture and sensitivity. This is an example of a case which was actually presented on day 1, but was treated with steroids. This is a case of TAS, which inflammation, and responded to topical antibiotics and steroids. This is another situation where we had a hypopion, and whenever you have a hypopion, and always you should try to err on the side of infection because it is safer to err on the side of infection. So in these cases, you must give intravitreal antibiotic. And here I will present to you a small little device which I have made, which is a glow fixator caliper and an intravitreal injection guide. So whenever you're giving an intravitreal injection, I think Saurabh will cover in more detail, the patient actually keeps moving the eye significantly. So it's possible that you might create a bleed, you may cause a trauma, you may actually cause a damage to the lens. So this particular device has got a semicircular ring. It's got a small little arm which has got markings at every 1 millimeter. It's got a platform which is present here which can actually press the puncture site, and this platform is such that it is that you puncture at a distance of about 3.75 millimeter but enter at a point of about 3.5 millimeters. That means your entry into the eye is valvular, and this valvular entry makes sure that when you go inside, you are when we did an anterior segment OCT, the valve closes. So this is an example of it being done. Once the intravitreal injection has been given, wait for the little while, come out, and then just turn the device by 5 to 10 degrees. This will cause a mismatch between the opening of the conjunctival sac and the sclera, and this would end up, when you lift it, you'll find a pristine conjunctiva with no bleb being formed. So this works extremely well. And so this has gone through multiple forms, and this is also used by retina surgeons for doing VR surgeries. Now TAS, it's important to differentiate between TAS, and the important things are in cases of TAS, there'll be a lid swelling and chemosis, while in case of endophthalmitis is usually little. The corneal edema in TAS will be limbus to limbus, while in infectious endophthalmitis it may be localized to the wound. The intraocular pressure may be elevated in cases of TAS, but in cases of infection, it may be normal or decreased. On a B scan, you may be able to find out exudation within the vitreous cavity, and culture certainly will be positive in cases of endophthalmitis. So essentially in TAS, you have to look at the causes. It can be from any of the fluids, can be from the viscoelastics, can be from your instruments which have not been cleaned well. So therefore, it's very important to have exacting standards in the operation theater to prevent these complications complications occurring. Even your ETO gas residues can cause TAS. So therefore, all these things are important. This is an example of a patient of a TAS treated over a period of time. So the best person to answer whether it's a TAS or an infection is the operating surgeon. The operating surgeon knows how much inflammation has been produced, and if you know, then you should treat it with steroids. Don't have to jump for a vitrectomy or giving intravitreal injections. This is another patient who responded well with topical steroids. But once you find that the patient is worsening, you must make sure that you get the culture report, and if you're already given the intravitreal injection, you may have to go in for a vitrectomy. So the key issues are, should not delay. Delay is the most important cause for problems occurring. You must not delay in diagnosis and must not delay in doing an appropriate intervention. You should not hesitate to give an intravitreal injection. You should err on the side of infection if you're not sure whether it is TAS or infection. So you have to differentiate between TAS and infection, and this is a patient who was treated with intravitreal antibiotics with vancomycin, did pretty well. And I've told you the differences. So the gray zone is, if in doubt, treat it as infection. If it is pure inflammation, treat it with steroids. Patient will improve within 24 to 48 hours. If you suspect an infectious component, the patient will not improve, may actually worsen with steroids, must give an injection. So all on the side of infection, do not delay, otherwise you will regret it. So this is a patient which I have actually borrowed it from Dr. Lalit. So he had cases of multiple cases which were treated. It was a simple looking surgery. 3 patients presented well on a Saturday evening who had good vision. They underwent VR surgery. They developed endophthalmitis. And there was panic in the hospital. There different advices were given. Then they were treated with intravitreal antibiotics. This is day 1, day 0, day 9. Patients did well. So please remember, intravitreal antibiotics are extremely useful if given on time, given early, and given appropriately. So this is again an example of a patient who did well. This is a current indication for vitrectomy, which I think would be covered subsequently by my speakers following me. And Avastin should not be taken up lightly, can cause endophthalmitis, similarly with Ozurdex. So take-home messages, apart from saving eyes, save yourself. Must document, talk to the patients and relatives, discuss with colleagues, refer if needed. Thank you very much for your kind attention.
Thank you, Dr. Ajay. As Dr. Ajay has highlighted, like any intraocular inflammation following cataract surgery or any intraocular surgery, if there is unexplained inflammation, which you are expecting actually more than what you normally found in your patients, you should err on side of infection. And whenever the patient has increased inflammation, you should start the patient on topical steroids with antibiotic combination 1 hourly, half hourly, and you should see the patient again maybe 6 to 8 hours later whether the patient is responding to your treatment or not. There might be worsening. It could be a gram-negative endophthalmitis, which usually presents on first or second post-op day, and the progression of endophthalmitis is very fast. So it is very important to see your patient very frequently on the same day whenever you suspect any infection, and if any infection doubt is there, like a lot of fibrin and your surgery was uneventful and a lot of hypopyon, you should not think like I should not give any intravitreal injection of antibiotics or what. You should take help of your any retina surgeon and think about giving intravitreal injection. I'll show you one case scenario where the patient came to us a post-operative 4 to 5 weeks. Can you put it? It was a patient who presented to us 4 to 5 weeks after surgery, vision 6/9, 6/12, decreased vision in between, and topical steroids were coming on, and the vitreous cavity was clear when examination was done, and vision was 6/9, 6/12. Again, the topical steroids were increased, condition better. Again, topical tapered. Again, same situation after 1 month. So this was a case having recurrent inflammation and inflammation coming down with steroids, but again, when you taper, it again came back. So whether it is end-off or you can say sterile inflammation, Dr. Grewal, will you please comment? patient having recurrent inflammation, once you taper off the steroids, it increases, then again you step up your topical steroid, it goes off.
Vitreous tap has been done?
No, sir, nothing was done. It was just conservative management from the cataract surgeon.
This needs aggressive.
Yeah.
Go inside and see what
We need to see. We need to take a sample from the eye, maybe aqueous tap or vitreous tap. So this patient was taken for aqueous tap, and it was done in the OPD because you can do in a sterile room where you can do your minor procedure. It can be done, and you can see once this tap was done, this as soon as the needle entered into the capsular bag, so much of exudates came from the capsular bag. This was a picture which was taken in the OPD itself. So you can see the enormity of a problem in the eye. All the capsular bag was sequestered with the pus which was not visible. Then the patient underwent AC wash and intravitreal injection was given, and this was a picture you can see. So this type of scenario, you should not avoid thinking like it is just some inflammation going on. It is some low virulent organism which is there inside the eye. If you don't take steps properly, well in time, you can land up into other problems also. And it can be a case of fungal endophthalmitis also, which can have indolent course or staph epidermidis case. So with this thing, I'll hand over to Dr. Saurav Luthra for his next talk on intravitreal injection techniques.
And Neeraj, classically in such a situation, you must, this was obviously a different one. We have to think in terms of P. acnes, which
Yes,
keeps recurring and you are not able to reach this. So we must keep that in mind.
Yeah, P. acnes, staph epidermidis, and
sometimes
fungal
the fungus as well.
endophthalmitis. Yeah, these are one of the most common of them.
Thank you, Dr. Neeraj. Good evening. I'll be talking mostly on the preparation of intravitreal injections because Dr. Ajay has given a very nice overview of intravitreal injections for endophthalmitis. So this is how an ultrasound B scan looks like. We see significant exudates in the vitreous cavity, which are usually low to moderate reflective, clump-like echos, retina is attached, and choroidal thickening may be present. So the indications, we know that when in any case where there is a clinical suspicion of endophthalmitis, vision is more than hand motions, vitreoretinal facility is not available in the vicinity, it's buying time for VR intervention, and also at the completion of vitrectomy that we give intravitreal injections. It's the mainstay of management strategy. Systemic antibiotics do not reach the intravitreal pathogens because of the blood-retinal barrier, as Dr. Ajay had told you, and to bypass this, we use intravitreal injections. So ideal agent is effective against offending organisms. It is non-toxic to retina in bactericidal doses, appropriate half-life within the vitreous to be effective, injected prior to the irreversible destruction of the retina and other ocular tissues, and it is easily available and cost-effective. So these are some of the commonly used antibiotics. And for gram-positive cocci, vancomycin is the preferred one. For gram-positive bacilli, vancomycin. For gram-negative cocci and bacilli, ceftazidime, amikacin and gentamicin are used, and for fungus either amphotericin B or voriconazole. These are the doses of these drugs which are used. So this is just a chart telling the same, and this chart was also shown by Dr. Ajay. So the importance of showing this chart is that it is very nice to keep this chart handy in the OPDs, in the operation theatre, so that you can readily make these drugs and inject them without any delay. So I will be showing a video of this, but generally vancomycin, you do a single dilution by making, at first you reconstitute with 10 ml of water, and then withdraw 0.2 ml of this, discard the 0.8 ml, and then again make it up to 1 ml. And this way you get a concentration, the desired concentration of 1 milligram of vancomycin in 0.1 ml of solution. Ceftazidime is also single dilution, whereas amikacin and amphotericin B are usually made by double dilution. So during the video, I will tell you how this is done. Dexamethasone can directly be injected by withdrawing 0.1 ml of this solution, but we have a caution here that in suspected fungal endophthalmitis, unless you have proven that it is KOH negative, one should never inject dexamethasone intravitreally, because if you have injected inside, you cannot withdraw that drug out. So once you have a KOH smear negative in a suspected case of endophthalmitis, and you have ruled out fungal endophthalmitis, it is only then that you should use intravitreal dexamethasone. So the surgeon injecting must prepare the solution himself. There should be a printed reference paper, aseptic precautions. As we said, betadine is so important, and it can be done in the OPD or OT setup. Informed consent should be taken, and care should be taken for wound integrity, suture abscess, and IOP. prepare the solution in separate tuberculin syringes and use a 30 gauge needle to inject under topical anesthesia and applying povidone iodine and draping an eye towel and using a lid speculum. So I'll just show you, I think I'll directly go to the video because that covers all of this. So this is what a tray typically looks like, and this is an older video, and as you will see that these are 3 tuberculin syringes, and these are the 30 gauge needles. There's a lid speculum, there's a caliper to measure. So first we reconstitute the vancomycin by injecting 10 ml of distilled water. Nowadays we do not use saline because that is not the recommended thing. Earlier even we could use saline, but nowadays it is preferred that we use distilled water. Similarly, ceftazidime is reconstituted. So this is a 500 milligram vial. So we will inject about 2.2 ml of distilled water to reconstitute. So after shaking this vigorously, once they have kind of dissolved and it's a homogeneous solution, we withdraw 0.1 ml. And then with single dilution. So this is the important step, that the final 30 gauge needle which you are going to use to inject, that should be used while discarding. So first we are just making it up to the desired thing, and this we are diluting with saline, but nowadays it's preferred to use only distilled water. So then you withdraw some air into it intentionally and allow the air, you tap the tuberculin syringe gently so that the air bubble travels from one end to the other, thereby mixing the solution so you don't have a non-homogeneous concentration of the drug inside the tuberculin syringe. I'm sorry, this is a little too bright. What we are basically doing here is doing an aqueous tap. So this actually serves 2 purposes. One, you get a sample. It's a little too bright, you can't really see the details there, but basically we are entering the anterior chamber and doing a paracentesis or removing aqueous from the AC, and this serves 2 purposes, not only giving sample for analysis but also reducing the IOP and creating space inside the eye for the intravitreal injections. So this is the drug which we had prepared. So this is following total aseptic precautions and applying betadine, which we have already done. And the lid speculum is already applied there after draping the patient. And we can measure 3 millimeters in aphakic and pseudophakic patients from the limbus and 3.5 millimeters in phakic patients. That's the usual way of doing an intravitreal injection. But if you're using the device made by Dr. Ajay Arora, you don't really need to do that to measure it. You can directly use that, and it is quite handy to inject. So it is good to use a 30 gauge. I prefer to use BD needles because they are very sharp. So I'll just go back to my presentation, which I'm just a few more slides left. Can you go to slideshow, please? So we should, after taking the sample, we should send it for direct smear and cytology for gram stain for bacterial culture insensitivity and KOH preparation for fungus. So do a thorough AC wash to decrease the toxic load, reinforce the section if there is leakage, check the IOP, send the sample to lab, entry with 30 gauge needle to pars plana to reach the mid-vitreous cavity. Bevel of the needle should be pointing away from the macula, or upwards it should be pointing. That is very important because you can cause toxicity with the drugs on the macula. Inject the antibiotic into the vitreous cavity drop by drop, and second injection should be through a different syringe. So there is this report, and Dr. Neeraj also showed that you can do an aspiration from the bag. And this is the same case which Dr. Neeraj showed, which improved after AC wash and after intracranial and intravitreal antibiotics. Improvement of vision, however small it may appear, is a sign of improvement. Reduction or disappearance of hypopyon after sitting up for 1 hour or more, clearing of the AC, consolidation of the fibrin exudates or shrinking of the pupillary membrane, better red reflex, reduction of pain, decrease in lead edema and chemosis if it was present. These are all signs of improvement. So this is a post-treatment, good result that was obtained. This is another patient at 8 weeks after intravitreal injection. We see that it has totally cleared out. So the carry-home message is timely diagnosis and treatment of post-op endophthalmitis can save most of such eyes. Endophthalmitis, once suspected, cataract surgeon should start the patient on conservative treatment with intravitreal injection of antibiotics and send the patient to the friendly VIA surgeon for further management. Thank you.
Thank you, Dr. Saurav. One question, what is your take on your intravitreal antibiotics like linezolid,
Nowadays,
tazobactam?
yes. So nowadays we are seeing a lot of resistance to the conventional antibiotics. So newer antibiotics like tazobactam and imipenem and even linezolid are being used. So yes, I mean that day is not far. Then all these antibiotics may become redundant because of resistance. So yes, we do come across cases which are resistant, and we have to use these newer drugs.
Right. Any question from audience? We can take one question related to.
Sorry? Yeah, so that those doses are there, and they are available. I mean, this information is available, and but again, since those cases are not so frequent, I haven't covered it in this presentation because it was meant for the regular cases of endophthalmitis that we have to deal with.
Those antibiotic dosage are there. Meropenem is 100 microgram per 0.1 ml. Tazobactam is 225 microgram per 0.1 ml. Idea is like you cannot memorize the doses. You need to have a chart how to prepare it, how to how much dilution should be done. It should all be written, documented over there. You cannot remember. It is not possible. Even routine antibiotics like vancomycin, we always see before preparation, because one dilution wrong means you are injecting maybe 100 times of what antibiotic you should have injected. So it is very important to know the dosage also and how to prepare that. Yeah. Can you come over there, please? Now, next talk is by Dr. Ajay Arora. Okay, so we'll have Dr. Naresh for anti-VEGF.
Yeah. Sorry? Meropenem, yeah. So we have used, as I mentioned, that in those cases which are resistant to these antibiotics, the doses are mentioned there, we have used, and they do respond. Sometimes nowadays we are seeing a lot of vancomycin resistant cases. So that's a very ominous sign, and we have to resort to using antibiotics like meropenem.
Yeah, but after vancomycin, what do you use?
Sorry?
After vancomycin, what do you use?
Yeah, if they are resistant to vancomycin, yes.
Culture sensitivity is very important actually. Now we have seen the patients are resistant to ceftazidime, but sensitive to amikacin.
Yeah.
Especially streptococci. So we are seeing such resistance coming up because of maybe you can say indiscriminate use of antibiotics, and people are using intracameral antibiotic after the surgery, cataract surgery is over. So we don't know which direction we are progressing, but yes, more we use antibiotics, more likely to we are likely to have resistance.
Actually, amikacin has seen a resurgence in usage because earlier it went out of favor because of macular toxicity, but with the reduced dosage of 100 to 125 micrograms, we are getting now cases which are sensitive to amikacin, so there's a resurgence of use of amikacin again.
So we have our next talk by Dr. Naresh. He will be covering on anti-VEGF related endophthalmitis, which is also very important in today's scenario.
Thanks, Dr. Neeraj, for giving me this opportunity. I will be speaking on intravitreal injections, endophthalmitis. So over 6 million intravitreal injections were performed in 2014, a number that is expected to continue to increase. And it is with great pleasure that I say that retinal surgeons are doing more procedures than anti-segment surgeons, if you take intravitreal injections into account. So, and post-injection endophthalmitis is a devastating event, because many times the patients have very good vision. We give injections when the patients have 6/6 vision, 6/9 vision. So you have to be very careful. If you land up with endophthalmitis, it's going to be very difficult. So this is a meta-analysis. So here a total of 534 articles from 2006 to November 2013 were analyzed for endophthalmitis occurrence. So a total of 4,45,503 injections were counted. So there were 103 cases of endophthalmitis in 1,76,124 injections. That is 0.058% with Avastin versus 0.029 with Lucentis. So Avastin had more number of endophs, but the crux of the situation was that this difference was due to a significantly higher occurrence of culture negative endoph. So the culture positive, there was no difference, only culture negative endophs was more with Avastin. So post-injection endophthalmitis can be either drug related, it could be because of the counterfeit medicine, or it could be because of the lapse in the cold chain. If the drug is not stored properly, not transported properly, this also can cause reactions. So the other could be procedure related, multiple use of the multi-dose vial. So Avastin we use it multiple times. So that itself can be a source. And then it can be injection related. If injection is not given properly, and if you have not used aseptic techniques. So this is a case that here from China. So out of 116 patients, 80 developed intraocular inflammation after Avastin injection. And all microbiological tests were negative. So the culprit was endotoxin. So endotoxin was confirmed by lab testing. And 78% of the patients recovered their pre-injection vision. So if the patients have infection with endotoxin, that is a sterile infection, most of the patients will do well. So this study implicated endotoxin as the cause of intraocular inflammation after the use of counterfeit bevacizumab. Those are take-home messages that don't change your supplier. Every day in a month you may get a call that I can supply Avastin in a cheaper rate. So always stick to reliable suppliers, don't change your suppliers. And culture negative endoph similarly reported from Yamashiro and Vikram Singh et al. So basically non-infectious endophthalmitis, it is because of endotoxin. This is a lipopolysaccharide derived from cell membrane of gram-negative bacilli, which can contaminate antibodies preparation solutions. This is something like TAS, what we discussed earlier. And this infection in the posterior segment is known as endotoxin-induced ocular toxic syndrome, that is EOTS. So the difficulty sometimes is that you are not able to differentiate. So it's better to err on the side of infection and treat it as an infection. And we have a lab test that can pick up the endotoxin. So that is known as LAL test, but it is not widely available. So the ideal solution could be that if you get the Avastin bottle, if you can get the endotoxin tested and then use that, I think that could be the best solution. And the other problem is fractionation related. So how to use the multi-dose of vial of Avastin? So either people keep withdrawing from one syringe, one vial and keep giving injections. Other, you make some 10-15 allocates out of that and then use it. So various ways of Avastin use are there. So the United States Pharmacopoeia advises allocating within a laminar airflow workbench, routine disinfection and air quality. That is class 5 environment. So that is the ideal. But people have shown that if you just withdraw from the vial also, that is good enough. In this study, 10 injections from the same Avastin vial were withdrawn. Only 10 injections. And Lucentis was taken as a single use. And this surgeon gave 1,184 Avastin injections and 471 Lucentis injection. And one patient who had received Lucentis developed infection. No patient with Avastin developed infection. So basically he concluded that the current study shows that as long as proper sterile techniques are implemented, there were no cases of EO from the use of the same vial. So proper technique, storage and fractionation is important. And this is the compounding pharmacy where most of the big institutes follow this, and in the US this is followed. But in this study, the Pan-American Collaborative Retina Study Group reported more frequent endophthalmitis in eyes injected using previously compounded aliquots. The problem is that once there is a problem in the vial and you allocate the vials, and then everybody is going to get that infection. If you are going to give only 5 to 6 injections in a day, then you are likely to see the patients immediately and you can discard the vial. Here you allocate and keep it them. So that is the problem. So, but there are a cluster of endophthalmitis with streptococcus reported in Miami, Florida, United States in 12 patients. And the same organism was found in cultures prepared from unused syringes. So the unused syringes themselves were contaminated. So there is no final word on fractionation. So the compounded Avastin is stable. You can keep it for a month or so. But still, if you allocate it, there's a microbial contamination is still a concern, since Avastin vials are preservative free. But the problem with multiple drawing from the same vial is that every time you poke a needle, you are likely to introduce infection. You are going to touch the stopper with a dirty gouge, dirty finger, poor respiratory techniques, and you can inject air when you're withdrawing the syringe. So all this you have to be careful. So this is the ideal way what the is recommended. It's under a laminar flow. The laminar flow workstation can provide class 5 environment. The room is first cleaned with a charged pre-filter, and there's a HEPA filter there, and under that you make the allocating. And you see that that is a mini spike that is shown down. So this is a better option. You don't put a directly needle and withdraw from there. With that way, there's a chance of air entering the vial. With this, the chances could be less. It's a little, you get a 3-way stopcock also. So with this, and this could be a better option. And the use of topical antibiotics. So the DRCA network recommends that there's no benefit of prophylactic topical antibiotics. And Crystal et al. Showed that the overall rate of endophthalmitis is greater with the use of topical antibiotics given immediately or for 5 days after the injection, compared with no antibiotics. And the disadvantages of frequent antibiotics could be an increased risk of bacterial resistance, and there could be a colonization by more virulent strains that can overcome the host defense mechanism, resulting in a higher likelihood of ocular infections. So basically, presently, we are not really, most of us don't use antibiotics. This is the main thing, risk reduction, that is by the use of povidone iodine. So this is very important. The only agent proven to reduce the risk of endophthalmitis after surgery, inexpensive, bactericidal, with rapid kill time, no reported resistance, anaphylaxis. So either you can instill or you can irrigate. So there are 2 ways to do that. And where should the injection be given? So in this study, 3,336 injections were given in the OPD, 8,873 in the OT, and in the OPD, 4 patients had end-off. OT, there was no end-off. So the setting is very clear that it should preferably in the operation theater. Face mask is important because the studies have shown that streptococcus is more commonly seen after post-injection infection. So and that comes from the oral. It's not from the patient's, the area around the eye. It is from the oral. So oral can be prevented if everybody puts a mask. So that is important. It's preferable. And the same thing, I think this is biosimilars also. Biosimilars are biologics. So it is not easy to manufacture them. And so basically we had a 10% rate of inflammation when the biosimilar, that is Razubam, was introduced. And then they took proper care. And with the new batch, they have added a fresh ultra-pure polysorbate. And after that, the inflammations have come down. So basically, follow a standard operative procedure. Preferable to perform the procedure in the OT, put a face mask, scrub, and don sterile gloves. Instill 0.5% paracaine, instill 5% povidone iodine in the eye, wait for some time, clean around the eyes. And the other technique is no touch technique. Never use of gloves to part the eyelids. Always use buds to insert the speculum. And then drape the eye and use a sterile speculum. Flood the conjunctival sac with 5% povidone iodine and wait for 30 seconds. And then use a new 30-gauge needle. And the most important is check for the perception of light. You don't have to really dilate and look at the pulsations. So if you look for perception of light, that is good enough. And routine paracentesis is not recommended. And then put a drop of 5% povidone iodine and always see the patient within the next 1 to 3 days. If you're not able to see, at least tell the symptoms of the inflammation or the post of endophthalmitis. So to conclude, the cumulative risk increases with repeated injections, reaching approximately 1.3% after 2 years. And the endophthalmitis is more severe because the species is different. The streptococcus is more virulent. So usually you will have poorer visual outcomes, and most of the cases need vitrectomy. Prevention is the best strategy. Thanks. Thanks for the patient hearing.
Thank you, Dr. Naresh. I would like to ask one thing. What should be the follow-up protocol following anti-VEGF injection? And when is the onset of endophthalmitis in such cases, and what should be the line of management?
See, ideally, most of us like to see the patient on the first day. So, because you can't really call them after 2 days or 3 days, because most of the patients are from outside. So, it's logically is easier for the patients also to stay for one night. And most of the inflammations, if they come, most of them, at least you will pick them at the first day. Don't make it a habit that you come directly after 1 month. Sometimes we do if the patient stays outside. But always make it a point to tell the patient that if there is any increase in floaters, decreased vision, increased pain, discomfort, then they should immediately come.
Okay.
I think we are running late of.
All right. Any question from?
Putting the 5% pyrenoirin after the injection instead of putting the antibiotics.
Yeah.
Okay, thank you, Dr. Naresh. So I'll be covering the next topic, late onset and fungal endophthalmitis. What are the features and how should we manage such cases? The delayed onset post-op endophthalmitis, when the patient comes 1 to 2 months after surgery, the most common organism which we encounter are P. acne, Staph epidermidis, or fungal infections. And these forms have great variation in presentations. P. acne endophthalmitis usually present with chronic, low-grade, delayed type of endophthalmitis, patient not having any pain, just blurring of vision, photophobia, or some irritability in the eye. And this P. acne is basically anaerobic, pleomorphic, gram-positive bacilli, and it is a normal commensal of conjunctival sac. And this organism is able to stimulate the immune system, and it is resistant to killing by polymorphic nucleosides and monocytes, and it persists intercellularly after phagocytosis. This was a case who presented to us 8 months post-operatively, had good vision, glasses were given, but he was complaining of blurring vision, heaviness of 2 months duration, and whenever some eye drops, topical steroids were given, there was decrease in pain and blurring, and vision improved. So this was a picture you can see. When patient came again after repeated attacks, vision was 624, aqueous cells 1+, and mild hypopyon was there. And you can see fibrinous membrane around the IL, which is around the optic and going along the haptic also. And vitreous cavity showed minimum haze. So question was whether we are dealing with ENDOF, yes or no. Most likely ENDOF, because the patient is responding to steroids, but again inflammation flaring up. So we decided to do a AC tap and send it for gram, QH, thioglycolate. It is an anaerobic organism, so we were to send for thioglycolate broth, seburodes, blood agar and chocolate agar, and to rule out the possibility of fungal endophthalmitis also. And this turned out to be a case of P. acne on the 9th day after culture on the non-nutrient agar. And this patient received intracapsular vancomycin because most of the pathology is in the bag itself from where the infection is originating. So we gave half dose of vancomycin in the bag and half dose in the vitreous cavity and started him on fortified vancomycin, topical steroids and atropine drops. So this was 2 days after surgery, 2 days after injection, vision improved to 618, and 1 week after giving injection, vision was 6/6, and fortunately there was no recurrence. But yes, if the inflammation recurs again and again, you may need to explant the capsular bag along with the IOL out also. But in this case, we could get away just by giving vancomycin within the bag itself and in the vitreous cavity. And Dr. Lingam Gopal also showed in a paper published in IGO, direct aspiration of capsular bag material should be done in case of sequestered endophthalmitis, what we did in our case also. Coming on to the next scenario, fungal endophthalmitis, which are not a common commensal of conjunctival sac, and it may mimic both, like bacterial endophthalmitis and chronic P. acne type infection. In acute type, mostly it is aspergillus or fusarium, which is responsible for acute post-operative endophthalmitis, or delayed onset is mostly because of candida. And it is mostly the irrigating fluid which is the culprit in most of the cases of fungal endophthalmitis, or the instrument contamination which you are worker may not have done in the operation theater. And incidence is more in India than the West. As I said, acute onset and late onset depends on the organism involved. And this is one of our case who presented to us with blurred vision, and inflammation was predominantly in the pupillary area. You can see fixed fibrinous exudates and hypopen here, and vitreous could be seemed to be clear, but it was deceptively clear in this scenario. And you can see in endophthalmitis, fungal endophthalmitis, exudate behind the iris or maybe along the iris plane also, or it could be a posterior capsular exudates sequestered in the bag, or there could be cotton ball-like exudates in the vitreous cavity. Once the patient with candida endophthalmitis comes to you, it shows apparent response to steroids initially, but there is eventually rapid worsening which happens over a period of few days only, depending on what kind of organism you are dealing with. Investigations, we can do aqueous tap, vitreous tap, or even the explanted IOL when you need to remove, you can send it for culture. And culture should be done KOH, calcofluor, and Sebrot's agar, and it should be sent for PCR to rule out any fungal primer also. PCR is because it increases your sensitivity by around 20%, which you are not able to pick, and it gives you a clue what kind of organism you are dealing with, whether it is a late onset endophthalmitis because of P. acne or staph epidermidis or fungal. You need to rule it out. Drug management is with amphotericin B, but high rate of retinal necrosis is there if any margin of, there is no margin of error. Usual intravitreal dose is 5 to 8 microgram per 0.1 cc. Fluconazole, we give oral 200 milligram OD or BD. IV dose is relatively safe. Intravitreal dosage is 1 milligram per 0.1 cc. Voriconazole is a newer antibiotic. It is given 50 to 75 microgram per 0.1 ml, and it is basically a fungicidal drug, and amphotericin is fungistatic drug. In surgical management, most cases would need vitrectomy. Only intravitreal injection will not suffice. IOL explantation may be needed in majority due to sequestration, and initial culture negativity is common, so you need to send it for PCR also. And you need to do a more complete vitrectomy in such cases. This was one of the cases who presented to us 3 months after cataract surgery, blurred vision. Another case having delayed onset endophthalmitis. Third case was sudden decrease in vision 4 days after surgery. You can see even the cornea also seemed to be involved. And all eyes typically had minimal pain and congestion. Exudation was predominantly limited to anterior segment in 2 cases. All eyes, we did AC wash, we did vitrectomy and intravitreal injection of voriconazole in the vitreous cavity, and half dose we gave into the bag itself, because it is the bag, anterior segment from where the infection is originating, that has to be taken care. Third case additionally required IOL explantation. Candida came out to be positive in 2 cases, and vision improved from 6/9 to 660. You can see first case and the second case doing well. Third case also, we could salvage this eye. So the carry-home message is high index of suspicion in culture-negative cases with deterioration despite intravitreal antibiotics and vitrectomy should raise suspicion of fungal endophthalmitis. PCR should be done. Vitrectomy needs to be more complete in such cases, and intravitreal voriconazole is safe antifungal drug. Thank you. So this was on fungal endophthalmitis, and we have a last talk by Dr. Ajay Arora. Vitrectomy, how much vitrectomy should be done, what is the rationale, and what should be the timing?
Thanks, Neeraj. This is just to, somebody was asking a question about the newer antibiotics. This is imipenem, which is 50 micrograms per 0.1 ml. Tazobactam is 225 micrograms per 0.1 ml. Carbanicillin is 2000 microgram per ml. Then you have ticalcillin, which is 3000 microgram per 0.1 ml. And then you have many other things like daptomycin and dalopristin. So these are the various drugs which are available. This was just by the way, since a question had come up, and I thought I'll just... So my talk is indication of recent advances in surgical management of endophthalmitis. This is how we would prefer a post-op case to be, not a disaster like this. And we must do everything to avoid this. And I think all this has been discussed by use of topical antibiotics, steroids, cycloplegics, anti-glaucoma medications, systemic antibiotics, intravitreal injections, and lastly we come to vitrectomy. The indications for vitrectomy are when the vision has deteriorated, which is light perception only, but But if the vision is better than light perception, if the patient is diabetic, then again vitrectomy is indicated. If it is a virulent infection and a progressively downhill course, fungal endophthalmitis, delayed onset endophthalmitis, no view on indirect ophthalmoscopy, and pacification of the vitreous with a macular pucker. These are the other indications, like beyond postoperative endophthalmitis, like post-traumatic, delayed onset, bleb-associated, endogenous, and vitrectomy is sometimes done for removing the vitreous membranes and treating a macular pucker. How does vitrectomy work? It basically brings out the material for culture. It reduces the amount of toxin and organisms within the vitreous cavity by basically debulking the vitreous so that our antibiotics can work. It clears up the media. It allows uniform distribution of the antibiotics. And the final fight, please remember, is not by vitrectomy alone, but by the antibiotics which are used in association with the vitrectomy. It's important to evaluate a patient of vitrectomy preoperatively by assessing the visual acuity, looking at the anterior segment for corneal edema, wound exudation, AC exudation, aisle position, because if you are not able to see behind, it's not possible to do a vitrectomy. Therefore, the anterior segment should be reasonably all right before we operate. The indirect ophthalmoscopy, we have to look at the amount of exudation, association of retinal detachment, choroidal detachment, intraocular foreign body, and the disc status and the status of the other eye. Saurabh has already told you about looking at the USG findings. We have to look at retinal detachment, choroidal detachment, and intraocular foreign body. And if you have a poor visualization of a ring abscess, a friable conjunctiva, then it becomes difficult. The problems during vitrectomy is that you may not have a PVD, and so it's difficult to do a complete vitrectomy, and we normally do not wish to induce a PVD. There may be an associated RD, intraocular foreign body, or the congested choroidal vasculature. Now, the steps in vitrectomy are: you must clear the AC exudate so that you're able to see well behind. You should insert a 6 millimeter infusion cannula because you don't want to create a suprachoroidal effusion by your cannula itself. You must take a sample and a smear for culture. Vitrectomy should be done till the optic nerve disc, where the optic nerve and the vessels have been seen. Do not try to induce a PVD, but if the PVD is already there, yes, you should complete a vitrectomy. Give intraocular antibiotic injections, and ancillary measures are intraocular foreign body removal. In case you may have to sometimes do a laser or a radical vitrectomy. So this is a small little video which, while it is running, I'll show you. So we should use a peribulbar anesthesia, use anterior chamber maintainer for that a 23 gauge maintainer, so that you can clear off all the membranes in the AC. So once this is actually an older video. So you can see here we're entering with the MBR blade. We remove the membrane from the AC. Once the AC membrane is removed, one is able to visualize inside. I have had two instances where we have removed the membrane. We looked at the vitreous cavity. The vitreous cavity was reasonably clear, and we decided not to go ahead with the vitrectomy, give intravitreal antibiotics at that point of time, and the patient did well. So I'll just speed process it. So this has been done, and then you go ahead, remove it, and do a vitrectomy till you are able to see the optic nerve, and that's the end of the surgery. So this is another situation where we go in with a microincision vitreous surgery. So you can see here, this is being done. You identify the cannula, ensure that it is not suprachoroidal, and then you go ahead and operate till you are able to see. You can see the optic disc and nerve, and once you have reached that point, it's better to remove as much vitreous as possible, remove as much exudation as possible, not to induce a PVD, and then you can go ahead and give the intravitreal injections. So the vitrectomy steps are: you must use a good vitreous cutter. Invariably it happens that whenever the vitreous cutter becomes blunt, we etiosterilize it and say this can be used subsequently for a vitrectomy procedure in an end-off case. That's not good, because those cutters have become blunt, and it's not good to use blunt cutters in an end-off case. You should get a maximum cutting and minimal suction. You must clear the vitreous debris behind the lens, and so you should do a cold vitrectomy, continue till the retina is seen and you're getting a bright red reflex, and you're able to see the optic nerve and the vessels. And this, I think, I have already alluded to. You should use systemic therapy, And you should send the case sample for culture, as Neeraj has already told you about fungal endophthalmitis, P. acnes, and staph epidermidis endophthalmitis. Now, there are cases where you can have a recurrent endophthalmitis, and these situations initially may look unmanageable, but once you persist with them, you can create a situation so you remove the entire exudate from the AC. This whole thing comes off, the eye is very congested, and once you're able to get that off and have a reasonable clarity of media, then one can go inside and do a vitrectomy, and it generally works out pretty well. Sometimes you may have to do a radical vitrectomy and explant the IOL. Now, the visual prognosis, there's a threefold increase in visual acuity after vitrectomy, 50% decrease in frequency of severe visual loss. The final outcome in 57% of the cases was about 20/40. There was no differentiation of visual outcome with visual acuity of hand motions or better versus intraocular antibiotic injection after post-cataract surgery. Now, whenever we have an associated retinal detachment, don't give it up, because these patients cannot be told that nothing can be done. So we normally end up doing a belt buckle vitrectomy with a vitreous-based dissection, which means a radical vitrectomy, and we are prepared for a silicone oil injection. Still, it is better not to create breaks in these cases. We normally, after having done a complete vitrectomy, having done a fluid exchange, we inject the intraocular antibiotics, and then go inside and put in silicone oil, or sometimes, rarely, these antibiotics have to be injected even post-operatively, and they can even be injected in a silicone-filled eye. I think this case has been shown earlier. So if you have a case where you have P. acnes, then sometimes what happens is they don't respond to your vancomycin. Then in these cases, we go inside, we actually remove the posterior capsules, make a small opening in the posterior capsule, give a wash to the bag, let all the washings fall in the vitreous cavity, remove all that from the vitreous cavity, and they have done well. And these are some of the examples of at the presentation, at conclusion. Again, the patient improved from 660 to 612, and this is again, patients are doing well. And these are patients after Avastin and Ozurdex. So the take-home message is, treatment failures are because of late presentation and delayed diagnosis, high virulence of the organism, inadequate drug concentration, and association of complications like retinal detachment, choroidal detachment, corneal abscess, and periocular infection. So consider an early vitrectomy. Do not postpone. If the patient is worsening, you can give an intravitreal injection maybe second time after 48 to 72 hours. If the patient is not responding, it's important that we operate. Always take a vitreous sample, because the antibiotics which you've used may not be actually working. Therefore, you need to have the culture reports with you. AC management is extremely important, because it will help you doing a better vitrectomy. Prompt pars plana vitrectomy must be done, and intraocular antibiotics injected. Use a good cutter, use a 6 mm infusion cannula. Do a debulking of the vitreous as much as possible. Do not induce a PVD. If the PVD is already there, yes, then it's worthwhile completing the vitrectomy. And for the patients who have a fungal endophthalmitis or a gram-negative endophthalmitis, they require immediate vitrectomy. Thank you for your kind attention.
Thank you, Dr. Ajay, for comprehensive coverage of vitrectomy as a whole. And I've been requested by Dr. Lalit to finish the session early, because that inauguration function has to go on. I would like to thank my faculty, Dr. Grewal, Dr. Ajay, Dr. Naresh, Dr. Saurav, for coming over, and to all of you for coming and attending this session. Thank you very much.
And for the audience to stay back so late.